I'm Dr. Reg Haid with Atlanta Brain and Spine Care. I'm a spine surgeon in Atlanta, Georgia, with training both in neurological surgery and orthopedic surgery. It is an honor today to host the first case debate series. This is hosted by Invasive. I'd like to thank our Invasive industry partners for helping us educate our surgeons. With that being said, I would like to kick off the first debate in our series. It's with anterior versus posterior thoracolumbar approaches for degenerative scoliosis. Again, whether you call this a debate or discussion, it's a matter of semantics. I tend to think of a debate as there's a right and a wrong way. And I think what you'll learn today with these discussants is there's pros and cons to each technique. So hopefully Joey and Avery will bring that out. Joey Laratta is an orthopedic surgeon in Norton Letterman Spine Center in Louisville, Kentucky. He's an associate clinical professor at the University of Louisville. Dr. Laratta will be taking the side of the anterior approach. And he's going to highlight minimally invasive anterior-based surgery for adult degenerative scoliosis patients. Dr. Avery Buchholz is a neurosurgeon at the University of Virginia. He's an assistant professor in the Department of Neurosurgery in the University of Virginia Healthcare System. Dr. Buchholz will be taking the side of the posterior approach, highlighting posterior-only surgery for the same patient population. And following their debate and discussion, I will provide some personal insights and comments and bring the discussion to a close. So let's first start with Dr. Laratta. Joey, take it away.
All right, well, thank you for the introduction. We're going to be talking about thoracolumbar procedural approaches, and I'm taking the side of anterior approaches, which I'm quite excited to do. I think there's been a real transition from all posterior-based approaches, the way I was trained in residency, to more of a swing back towards the anterior column and the importance of anterior interbody support. This is a 62-year-old female who's got a significant amount of back pain, and she says she can't walk long distances any longer, and she feels like she's leaning forward. So it seems like a sagittal imbalance type of problem, and she failed extensive non-operative treatment. Avery, I always have difficulty with non-operative treatment in the adult spinal deformity patient and which modalities are best. But I always go through kind of the gamut of what they are: epidurals, physical therapy, and I've largely recently been using water therapy to eliminate the kind of the effect of gravity on these people. And anecdotally, I've been liking kind of the results that I've seen. Have you used this in any patients?
So yes, Joey, we do use a lot of aqua therapy, and our patients have seemed to do much better being in a pool. And I think for the same reasons you mentioned, there's the effect of traction in a pool. It takes some of the gravity out of the spine, and people tend to do much better with therapy in a pool setting versus land setting, in our opinion.
Yeah, I think it's important both in helping patients avoid surgery, and then in those patients that are going to have surgery as kind of a prehab to get them stronger and through the recovery better. This patient's a non-smoker, and on examination, she has these compensatory mechanisms that we're all familiar with. When we look at her 36-inch sagittal, you can see that she has a significant mismatch of 51 degrees. She has pelvic retroversion with a pelvic tilt of 38 degrees and lumbar lordosis of essentially 0. On her AP radiograph, she's got a coronal Cobb angle of 43 degrees and 2 centimeters decompensated to the right. This is something that's really interesting to me, and I hope it's interesting to some of the viewers too. I think that while we know that routine activities of daily living can exacerbate functional disability in the adult spinal deformity population, we really have essentially a limited understanding of how sagittal parameters and compensatory mechanisms are affected by activity. But this slide shows this really nicely. We all, I think, as surgeons, understand compensatory mechanisms of patients with sagittal imbalance and how these mechanisms relate to the Dubochet cone of economy. But we indicate all of our surgeries and we plan all of our deformity surgeries in terms of what osteotomies we're going to do, where we're going to do ACRs, all off a single standing 36-inch film, when really a single 36-inch film is simply a snapshot point in time where a patient can really maximally compensate. So what I tend to do, as you can see here, I think that after patients walk for 5 to 10 minutes, they can suffer a loss of compensatory mechanisms due to fatigue on the pelvic and spinal extensor muscles. So I reevaluate their sagittal parameters after walking to try to unmask a hidden sagittal imbalance in someone who's got a compensated deformity. So you can see in the figure on the left, on the 36-inch lateral, she's got poor pelvic parameters in terms of her pelvic retroversion, but she's globally compensated. Her SVA is only 5. But after 5 to 10 minutes of walking, she starts to decompensate because her pelvic muscles and her spinal extensor muscles start to fatigue out, and you can get this hidden, you can unmask a hidden decompensation in these patients after they walk for a while. And this isn't really that well described in the English literature, but it's actually pretty well described in the South Korean literature. And you can see that she's got foraminal stenosis on the left side of the fractional curve, as well as stenosis on the right side at L3-4 and L1-2 and 2-3. The supine CT scan gives me a good sense of how these patients are going to correct on the table. It's a good adjunct to use in your deformity correction planning instead of a supine lateral x-ray. In this patient, you can see that she's got fixed lumbar kyphosis of 6.8 degrees. You can see the segments at L5S1, L4-5, L3-4, L2-3, L1-2. The coronal CT scan is something I like to use significantly when I'm planning which side I'm going to do my minimal access lateral technique from. You can see here at L2-3, the patient is relatively fused on the right side. Now, I'm not as good as a surgeon as Avery is, so when I see anterior fusion through the disc space, this is a cohort of patients which, in my hands, is relatively difficult to correct posteriorly. But with these minimal access lateral techniques, this is relatively straightforward. So this patient was someone that I indicated for a multi-level anterior lumbar interbody fusion with an ACR at L3-4. You can see our final correction. It was a T10 to the pelvis posteriorly that was staged after a multi-level lateral lumbar interbody fusion anteriorly. You can see the difference in pre- and post-operative comparison, relative correction of her coronal alignment, and nice harmonious correction of her sagittal alignment. I think that in this case, lateral lumbar interbody fusion really allows for powerful coronal correction, and when we combine this with an anterior column release, powerful sagittal correction at the same time, I think that by having interbody support at nearly all these levels, we can really limit the amount of BMP that we use, and we can deliver a large amount of graft to the interbody space. And I think lastly, something that we really shouldn't just breeze over, particularly with cages such as the modulus cage, there's a real high coefficient of static friction because of the surface technology. And I think that really allows for early, strong apophyseal fixation, and that obviates the need for these 3, 4, 5, 6, 7 rod constructs that we use not uncommonly with all posterior techniques.
So Joey, that's an excellent outcome. Super happy with the correction, and I'm sure your patient's doing well. Is this something you would stage over 2 days, or is this a same-day surgery?
That's a great question. I don't think we have great evidence to say when these procedures should be staged, when they should be single stage, single position, when they should be single stage but flipping the patient, and when these should be 2 stages and open versus percutaneous procedures in the back. It all depends on the amount of deformity correction that I'm going to need. If it's going to be like an L1 to S1 or L1 to L5, and we're going to do a small coronal curve that's 20 degrees, and I'm not going to ask too much of posterior osteotomies, that's something I might do in a single setting with a single position lateral and percutaneous instrumentation in the lateral position. But most of the time, once the curves get to 40 degrees and there's a significant sagittal imbalance that I really want to get good wide posterior column osteotomies, I'll typically stage them and then do an open hybrid approach. So I'll do my minimal access stuff laterally on one day, and then the next day I will do open posterior osteotomies. Even though I'm supporting the anterior approach, I think it's really important for all of us to understand that without facet releases in the back. And Juan's done a study on this in cadavers years ago, and many people have talked about this on the podium. Without wide osteotomies in the back, you really don't get the lordosis of the cages that you're putting in, right? So if you're putting in a 30-degree cage in the front, but you're not doing a facet release in the back, you're probably only getting 50% of what the lordosis of that cage is. So I think when you really want to correct someone sagittally, you got to do something open posteriorly in the back.
So with this patient we're looking at here, you have great sagittal correction, great coronal correction. Is this something you did where you opened up posteriorly and did some facet release, assuming?
Yes, exactly correct. Yeah. So this is someone
okay.
I did on day one. I did laterals and an ALIF, and then on day 2, I did an open posterior T10 to the pelvis. But you know something, when you do the open posterior after you do your anterior stuff, it really makes the posterior a lot easier because spine's relatively loose. And once you do those osteotomies in the back after you released laterally, spine falls exactly where you want it. It's having that posterior wide posterior column osteotomy that we do for deformities, in addition to, releasing laterally and taking out the disc so efficiently through the lateral approach. You can really manipulate the spine in whatever alignment you'd like without stressing your instrumentation.
All right. So again, my name is Avery Buchholz, and I'll be looking at the posterior approach to thoracolumbar procedures here, specifically adult deformity. And so Dr. Laratta just gave a great example of a minimally invasive anterior-based surgery for adult degenerative scoliosis patients. I'm going to look at the posterior-only approach. And so this patient is a patient of mine, a 71-year-old male who has an adult degenerative scoliosis. He has progressive back pain and leg pain over a number of years. We've exhausted conservative measures for this patient, physical therapy, pool-based therapy. Dr. Laratta mentioned that as well, and we found that also to be an effective technique, and patients seem to do much better with that compared to land techniques. The patients also had injections, medications, and we've gotten to a point where the pain has progressed, quality of life has decreased, and the patient's also starting to have some weakness in his right foot dorsiflexion, among other areas of nerve impingement and radiculopathy. So we've gotten to the point where we're going to elect to proceed with a surgery here. On this slide, you can see preoperative deformity. They've got a significant mismatch of 32 degrees. They've got significant sagittal imbalance. And coronally, they do have a coronal Cobb angle 44 degrees, but overall they're balanced, and still the head is above the pelvis where we like it to be. But the patient's significantly painful, and we've elected to proceed with surgery. So as a disclaimer, I do minimally invasive surgeries. I do XLIF, I do ALIF, anterior surgeries, and whenever I can do those procedures, that's what I tend to favor, and I try and do those whenever I can. For deformity correction, in my hands, posterior alone, it seems to be more reproducible. I think it's less operative time. It seems to be less morbid on these patients, less time under anesthesia. It's a same-day surgery. There's no second stage procedure. And for these older patients who are often the deformity patients, the adult degenerative scoliosis patients we treat, I think less time under anesthesia is beneficial. I think less time in the OR is beneficial. And patients seem to do well. I don't think their hospital stays are any longer than the minimally invasive or staged anterior-posterior approach patients. That's my experience with it. And I'm curious to know from Dr. Laratta if he notices any change in hospital stay or length of stay with these patients when he does them anterior.
The hardest thing that I have to do in my practice is predict someone's recovery. Okay, the technical parts of surgery are relatively simple, and I think we can all teach anyone how to do spine surgery. It's not overly complicated, but predicting how someone's going to do after surgery is really hard for me, and predicting when recovery, whatever that may mean, occurs is tough, and especially in deformity patients. There are some patients where, again, I do all posterior-based techniques as well for deformity. There are some patients that I do, minimal access lateral things, and then I stage it with a posterior, and they're out of the hospital in 1 or 2 days after their second stage. There are some patients where I do that, and they're in the hospital for 8 or 9 days afterwards. I don't know exactly what drives a patient's length of stay in my hands in this population, but I've had, I've seen it on both sides of the fence, both with open posterior techniques and minimal access lateral techniques, where patients that I expected to be really quick movers ended up staying for a long time, and people on the flip side of the coin really surprised me and were able to mobilize quickly and get out of the hospital. So long-winded answer, but really, I don't know.
Yeah. No, and I agree with you. I think I've seen the same thing. Some patients have minimal work done and horrible pain, and some patients, open T10 to pelvis and feel great and go home a few days later. So it's really hard to predict. But overall, I would say my open posterior patients is as big as the surgery it is, I'm always surprised how well people do. And people are always surprised that they're not in as much pain as they would expect themselves to be. So here I have a CT scan, coronal and sagittal view of this patient. I did not include any MRIs for this case, but the patient does have nerves being pinched, radiculopathy, foraminal stenosis. You can see on the myelogram here, we do see some stenosis. But the thing I'm really looking for is the air in the disc space. When I see the air in the disc space, I know that it's going to be a relatively easy correction. I'm not going to have to do a lot of work. I just have to do a facet release things posteriorly, and most of the time we'll be able to correct them fairly easily. Joey showed a great case of using inner bodies to do this. I think that's a great technique. I think the fusion that provides is beneficial. I'm going to rely more on my posterior fusion to achieve the same thing, and I don't use the cages and inner bodies to correct. I'm going to get this with all a posterior release. And like Joey mentioned, a lot of times to get a proper release, he's still going posteriorly and doing some facet work also. So that's kind of what I look at in these films, and that's what I'm seeing here. So here we have our postoperative images for this patient. We did a T10 to pelvis corrective surgery, pedicle screws at each level. We did a T-lift at L4-5 and L5-S1, and this was primarily for fusion. When we do our T-lifts, we'll do a big posterior column osteotomy where we take down both facets bilaterally. We'll do a distraction cage, distraction rack, or a temporary rod with distraction. And we'll distract posteriorly, do our disc work, and try and put a big cage way anteriorly. So we're essentially the same technique as doing an anterior column procedure, A-lift or X-lift, but we're doing that from behind, putting a big cage anterior and then compressing posteriorly. And so we do get a lot of correction with that cage. We didn't need a ton of lordosis in this case, but we do a lot of that. So we do that 4-5, 5-1. As Joey mentioned, we do use a third rod in this case. We've used fourth rods. We did find that at 4-5 and 5-1, there is some percentage of pseudoarthrosis and rod fracture. We started using cages. That's something Dr. Chris Shaffrey made popular, and we've been doing that also. We haven't had a problem with pseudoarthrosis or rod fracture using a third and fourth rod up to this point in time. But that is something we do. Your point about anterior column fixation and the benefits of less pseudoarthrosis are valid, and I totally agree with you on that.
So, Avery, talk to me. It looks like, is there is that a crosslink at the top, or is that a tension band that you have at the top of your construct?
So that is an invasive versatile. It's a posterior column tether. So we use a lot of posterior column tethers for PJK reduction. Mm-hmm. So we'll tension that into, so we went to T10 for our final pedicle screw here. We do a polyethylene weave at T8 and T9 spinous processes and tension that into our versatile attached to the rod. And we don't have a specific place we put that. Usually it's 1 or 2 levels below the proximal pedicle screw. So here are my last slide with postoperative images. We saw in the previous one, we had fairly reasonable coronal correction. The patient was balanced coronally, so that wasn't our overall goal. But here, looking sagittally, we did also get a good sagittal correction. We brought the head back above the shoulders, above the pelvis, into a better alignment. We reduced the SVA. We reduced our PI-LL mismatch. And overall, we're happy with this correction. So again, this is something we did all posterior. I think there's a lot of surgeons who tend to do these cases all posterior, and it seems to be more reproducible for most people. And certainly there's some really talented surgeons out there who can do good anterior approach surgeries with X-lift, A-lift, and get great corrections. That's not been my experience as being the most reproducible thing for me. The other benefits, like I mentioned, are reduced anesthesia time, reduced time on the table, get a patient a good correction and off the table and a good result in a quicker way. The other thing is I would mention, we rely on our L4-5 and L5-S1 cages for fusion. Otherwise, we're doing a large posterior lateral fusion. Certainly interbodies is a good option for that, but there's also expense to that. And so we try and be good stewards of the hospital and try and minimize those costs, but certainly doing a good posterior lateral fusion is important for these patients. So you do have to rely more on carpentry for the posterior lateral arthrodesis than you would using some of the anterior techniques, which I think are great techniques, and I do use those techniques also. So that's currently my take on the adult deformity. I tend to do all posterior. I don't think either way is wrong, but for me it's been more reproducible to do posterior alone. Any other comments you have, Joey?
No, I think that you got a great coronal correction and great sagittal correction. Your parameters look nice. I'm sure the patient's doing really well. I think what you said is 100% correct. And this is supposed to be a debate, but I think you're 100% correct in that the gold standard for spinal deformity is the posterior approach. The anterior approach is interesting, and I think it can provide a lot of benefit in particular specific situations. One more thing I think we really need to talk about before we end this is you are right when we talk about cost and we talk about cost of cages. When we do these anterior procedures and anterior releases, more oftentimes than not, especially in anterior procedures and minimal access procedures, we use cages at every level. And as minimally invasive surgeons, right, we live and die by the interbody fusion. If we don't get that interbody fusion, then we're not going to get it. But we have to realize that, it may cut down on BMP costs, but we have to be stewards when it comes to how many cages we use and what is the most cost-effective thing going forward, especially in light of the kind of healthcare economy that we have right now.
Well, good. Well, two good cases, I think, and I appreciate you being part of this, Joey. And with that, we'll kick it back to Reg for any last comments.
Joey and Avery, I'd like to thank you once again for your discussions today. I think you both have done an excellent job of highlighting the pros and cons of each technique. Let me first start by saying there is not one unique proper way to do this technique. This can be done in a variety of approaches, both open, minimally invasive, and hybrid. What's most important is that each surgeon chooses his or her own approach to their basic skill sets and what they feel comfortable for. This has evolved over the years. I continue to evolve in my practice with what I do anterior or lateral or posterior or combined. And I think the one thing that we all know, if we had the same discussion 2 years from now, we would each probably share an evolving perspective about this. I first found it interesting that you both talked about aquatic therapy. And I think I ask patients if they get into a swimming pool. I've had a procedure, anterior and posterior for degenerative lumbar disease, and I found it just amazing that when I went down to see my parents in Florida, if I got into a swimming pool, my pain would just go away. So I think that is very good to understand if the pain is weight-bearing or non-weight-bearing. Joey, another thing you've talked about is actually compensation and decompensation. So when I see people in my office, I make a point of making them walk into my computer room and I make them stand there. I don't go to their particular patient room and watch them sit down. I want to have a patient, I walk outside, my nurse walks the patient down the hall, I look how they walk. Then I make them stand up while I examine them and ask them questions. Invariably, you'll see certain people start to bend over, lean on a counter, or ask to sit down. And I think, Joey, what you've done is by having them walk for 5 minutes and take a new set of x-rays where they're no longer able to maintain that compensatory posture, I think is absolutely key. That is absolutely key, and I just want to, I'm going to bring that into my practice, quite frankly. I think it's also clear that when you look at the literature, anterior approaches, ALIFs, provide improved lordosis and sagittal balance. And I've taught around the world with Juan Uribe and Chris Shaffrey about this. And it's clear from the literature, no matter who you look at, that an A-lift offers greater restoration of sagittal alignment and lumbar lordosis, notably at 4-5 and especially at 5-1, where the foundation is absolutely critical. If there's one place we have to get lordosis, it's at L5-S1. What Joey talked about is what Juan Uribe has taught us. Several years ago, Juan was, and he did my surgery, by the way, he was showing some X-lifts, and Chris Shaffer and I mentioned, you know, Juan, your coronal balance is incredible, but your sagittal not so much. And to Juan's credit, he went back and looked at it, and that was before doing sectioning the ALL. And Joey alluded to this, that unless you section the ALL with a lateral approach, you could not obtain optimal sagittal lordotic balance. An A-lift sections ALL and puts in a big spacer, and you're able to create great lordosis. An X-lift by itself does not give the best sagittal alignment. X-lifts give phenomenal coronal alignment. I do a lot of A-lifts, supine. It's a chip shot at 5-1. I go as high as 3-4. You really cannot go above 3-4 in an A-lift because of the inferior mesenteric artery. So I do a lot of A-lifts at 3-4, 4-5, and 5-1, where I can really get great height restoration and lordosis. A thing I always do is I get a preoperative CAT scan looking at calcification of great vessels. If you see great vessels calcified, it may preclude you from doing an A-lift at 3-4 and 4-5. Thus, if you see calcification of vessels, you may need to do an X-lift, or you may need to do a T-lift if you prefer interbody techniques like most of us do. If you want to go to 2-3, you can always do a T-lift or an X-lift, or you can do a pre-psoas approach as well. So you can combine all these approaches and do a pre-psoas approach at 2-3, 3-4, 4-5, and 5-1. I think what's most important is the surgeon have in his or her armamentarium a variety of techniques to employ. The X-lift also can be used to open up disc spaces that may appear to have bridging osteophytes. Joey did an excellent job of showing that bridging osteophyte. I think it was a 2-3 where you're able to go in the side and break that open. That's a little bit more difficult to do from a posterior approach. Let's talk about the posterior approach. So when I listened to these talented surgeons, I thought about Joey representing a Juan Uribe and Avery representing a Chris Shaffer. Avery trained with Chris, and so Avery is a highly skilled technical surgeon that trained at the foot of the master of T-lifts. Chris Shaffer is the best T-lifter I know, and I think Avery Buchholz is right behind him. As Chris and I teach around the world, we quickly find that not everybody has the same approach that I do, Chris does, and Avery does. What Avery's talking about is a deformity T-lift, where you go in, you do osteotomies, you place your screws, you distract, either use a spinous process distractor or a distraction rod. You do a very thorough discectomy, very anterior, and then you slide a spacer in anterior. This is not new. This was actually taught to me by Dr. Ogilvie, who was a deformity orthopedic surgeon at Minnesota, and his young associate, Dave Pauly, who later became president of the SRS, also described this in several papers. You place an anterior T-lift and then do posterior compression. So if you're going to get the kind of deformity correction that Avery talked about, bilateral facetectomies, extraction, complete discectomy, and an anterior placed device followed by posterior compression are absolutely critical. So in summary, I think these discussants have done a very good job. I agree with everything they've said, with the exception of Joey saying this is technically simple. I'm an old guy. I don't think it is. I've spent a lot of decades learning these techniques. But I've learned from visiting other surgeons. I've learned from visiting cadaveric labs. I learned the X-lift from Juan Uribe years ago in San Diego. So I guess to the people listening out there, I would just urge them to visit surgeons, to do clinical observation, to do live cadaveric, to do remote lab visits. And since NuVasive sponsored this, I can tell you that they're very proactive in teaching people open techniques, minimally invasive techniques, anterior, lateral, etc. So they can always contact their local rep for that. And to summarize, I just like to thank Avery and Joey for doing an excellent job. It's obvious that the future of spine surgery is in great hands. With an industry partner like NuVasive, I think will serve our patients well. Thank you so much.